Good morning. My name is Julie Garcia. I'm the executive director and founder of Jules Helping Hands. Jules Helping Hands is a nonprofit that specializes in helping people already experiencing homelessness in our city and county by providing basic needs with kindness, dignity, and respect. This is a panel of lived experience workers and frontline workers that are on the ground every single day with the populations we serve. I'd like to let my panelists introduce themselves. So Robert will go first.
Hello, my name is Robert Lipman. I work here in Spokane. I am the manager of one of the clinics here in Spokane under Providence Medical Group, and we are a walk-in clinic that primarily serves the homeless, chronic homeless, and also sit on the leadership team of the Spokane Homeless Coalition and a board member of the Continuum of Care Board. Megan, I'll hand it off to you.
Good morning, everyone. My name is Megan Peary. I'm from Spokane, Washington. I encountered being unhoused as a pregnant teenager. I have lived experience of incarceration reaching back to the early 90s. I overcame systemic barriers post-incarceration and have become a licensed foster parent and have 4 adopted children through the foster care system. I'm the co-founder and co-director of the Eastern Washington chapter of All of Us or None. I graduated from Spokane Falls Community College. I'm a proud graduate of our community college in the addiction studies program. I hold an SUDP license, or a substance use disorder professional license. My previous employment includes employment as a counselor with Pioneer Human Services and a community engagement specialist. And then I worked with the Bail Project as a recovery navigator or a reentry coordinator for people that would be bailed out of jail and were facing all kinds of barriers during their reentry. I participated in different parent-teacher organizations, worked as a volunteer YMCA basketball coach for at-risk youth. And one of the favorite things I love to do is register voters, work out in our community, working with the unhoused population. And I'm really passionate about strengthening families and working with previously incarcerated individuals in reentry and working to end mass incarceration. And I'll hand it to you, Barry.
Okay, hi, I'm Barry Barfield. I'm on the leadership team of the Spokane Homeless Coalition, along with Robert Lipman. I am on the City of Spokane's advisory board for the Department of Community Housing and Human Services. I've been sort of involved with homelessness issues for about 40 years. I am a licensed attorney in Washington and in California, but I haven't practiced in 30 years. What that tells you is I can't give you any reasonable legal advice, but I do understand and speak legalese. And some of you in this meeting probably do speak and understand that as well. So that's me. Thank you for being here.
My portion of the discussion is going to be on the barriers for people who are currently unsheltered in our cities. I first want to start out by saying the answer to solving homelessness has always been the same. The answer is housing. In order to understand how we got to the place we're at, we have to first look at how these systems were structured in the very beginning. Hundreds of years ago, when these shelter systems were getting set up, people had to decide who was able to and worthy, for lack of a better word, to obtain housing. Then white, wealthy men were the only people allowed to have home ownership or have access to housing. African-American men and women lived in stables, shacks, anywhere they could find housing. White women were not allowed to have a salary and or have home ownership, and Native Americans were marched off their lands and their titles taken. That's how our system started. Now we are at a point where that same system is affecting how we can get people in the situation that we created into a home. Housing is the only way to solve homelessness. Whatever housing looks like, homelessness means without a home. So the only answer to getting everybody off of the streets, off of couches, living in unsafe conditions is through some sort of housing. My job and my role in Jules Helping Hands is to research and look at and participate in solving problems for the folks that are currently unsheltered in our city and county. In doing this, I was a single mom who just started making sandwiches because I noticed people were hungry. Then I realized they were cold, and my one truckload of clothing turned into a clothing bank. We are community funded and community solution oriented. In doing all of this, the community funds this kind of project for us, and we have found some of the barriers to homelessness are easily corrected, and some are going to have to be fixed in the bigger system. One of the number one and main barriers to people experiencing homelessness currently in our cities and counties is criminalization of homelessness. Laws specific to people experiencing homelessness. One of those laws specifically is a sit and lie law, and that inhibits people from sitting and laying in front of businesses and on public property, and can be enforced by law enforcement. With that being said, creating those barriers for folks creates barriers that keep them from entering shelters, transitional living, and and housing. One of the other barriers is the way we talk and speak about people experiencing homelessness. The terms and generalizations that we use to describe a large population of people experiencing the same thing. Words used like addicts, labeling them as lazy, being exclusive, and the us versus them. Those are some of the talking points that are really big in my world that I live in, because it dehumanizes folks that are experiencing homelessness. I'm going to give you kind of an example of laws that are specific to homelessness that create barriers. Right now, Spokane is in a heat wave. Today it will be 100 degrees and we have no access to water. People unsheltered in our community don't have water, and there are rules and regulations that prohibit them from getting water. That may not have been the intention in the beginning, but it is the actuality of the law as it plays out right now. We have to begin to look at those laws that we are making and understand how they're going to realistically play out in our system. Police sweeps, those kind of enforcement laws and actions are utilizing data that we don't have availability to. Neither the people who are enforcing the laws or the general public or the people who the enforcement entails, the people experiencing homelessness. Where do they go? That's really the question to be asked, is when people are unsheltered, where do they go? Do they obtain housing or safety in shelters? Yes, that is an option. Yet we don't have enough shelter beds available for the populations that we serve. Low barrier beds, shelters, day centers, places where people can access services where they're at, not where we think they should be. Anybody in any condition. It is lack of low barrier beds across our country that is keeping people remaining on the streets. It is coronavirus and COVID. All of these things have, all they've done is they have highlighted where we have been lacking forever. We have always been lacking in low barrier beds. We've always been lacking in available services and the availability to those services. As our country changes and grows and technology becomes something that we use on a daily basis, those folks without access to those options have no knowledge of the changes and are unable to participate. Some of the other barriers to people remaining on the street is lack of services. It's not necessarily that we lack services altogether, because there are people in every city doing amazing things. Those services do not talk with each other. We don't communicate, and we're always trying to bend the wheel. I've learned this personally dealing with outreach, is starting off in doing this. I wanted to do everything, but I'm not a housing specialist. I'm not a drug counselor, and we need all of those players and participants. What we need is communication, both between service providers and between people experiencing homelessness and the people they're depending on for help. When we criminalize homelessness, so how a sweep or whatever it is called in your city is done, the enforcement comes in and moves people along. The law states that people can be asked to not camp in public. Those laws are enforceable, but they're only enforceable with the data that's needed to prove there is low barrier shelter beds available. I don't know what the answer is to low barrier real-time bed availability, but there are some really good programs.
Julie, someone put in the chat, what can you explain what low barrier bed means? Since you're addressing that, why don't you explain it?
So low barrier and high barrier, that's how we determine the way to access a shelter or day center. Low barrier means anybody can access it in any condition. There's obviously no barrier shelters that I know of, because there's being able to maintain in the environment in which you're at. But low barrier means anybody in any condition. There are no requirements. There's no sobriety. There's no anything involved with you accessing a bed that night for a specific amount of time. High barrier beds, equally as important, are beds that you must be sober for. Men, women, separation of those two, those are a barrier. Are they people able to sleep with their partner or next to their partner in the same building? So LGBTQ, any of those barriers, we call those barrier shelters if those folks are excluded from being able to participate. Does that answer low barrier, high barrier? So what is lacking in our system is the accessibility to anybody in any condition, regardless of their circumstance or situation. And that's my focus. All of these things keep people on the street, not understanding of Maslow's hierarchy of needs. Basic needs are not met. We're not able to move forward or up, or however you want to describe it, into other areas of our life food, water, shelter, safety, security. Those are all basic needs. Do I have any more questions on what basic needs or low barriers are? So imagine if you find yourself in a situation, you're sleeping in a city park. Why are you sleeping in a city park? I can give you the example from the folks that I deal with on an everyday basis, which is chronically homeless. When you go to even a low barrier shelter, people get banned from those shelters for behaviors, whatever the reason is that you're banned, but you find yourself banned from the facilities that are offering low barrier beds. Now, where do you go? To a park, to a doorway to sleep or get safety. And then along comes police officer or a code enforcement officer or the pod or whoever it is that's enforcing the fact that you can't stay there and you're asked to leave. The question is where do you go? There is very little places for people to exist without getting a ticket. And these laws are specific to homeless individuals simply for the fact that I don't need to camp in the public park. I have a home to go to. This is absolutely what they need. Their basic need is being met in this park at this time. When we move them from one place to the other all day long, they're unable to obtain services. Service providers are unable to even track down the clients, and folks are putting themselves in unsafe situations and in neighborhoods that aren't equipped to care for these folks. We need low barrier beds, and criminalization of homelessness based upon the data of low barrier beds needs to be visible to everybody. Everyone needs to know where there's a bed available. And if we're going to enforce our laws based upon that data needs to be accessible to everybody. One, to hold folks accountable, and two, to allow people the access to and knowledge of where they can obtain their services. And with that, that is my introduction in barriers to homelessness. And I'm going to turn it over to Robert Lipman.
Awesome. Thank you so much, Julie, for that. That was great information. My segment here is.
Can I interrupt for a second? Julie, you gave me the list of barriers. Would you like me to put that in the chat at this point?
Yes, there's an extensive list of barriers, one that I've compiled. It is necessarily not all of the barriers, so please forgive me if I forgot some or you'd like to add some, but it's clearly too much to talk about in a 75-minute session. I could probably talk about this for 8 or 9 hours, but I did post that list. Barry's going to post it into the chat, so you can look at if there's any questions regarding any of those, or you have any questions I can answer, please feel free to put them in the chat. At the end of our session, we will do questions and answers. Or if I don't have the answer currently, I will email you a response if you leave your email.
Awesome. Thank you again. And so my segment here again, if you just came in, looks like we have 102 participants. That's awesome. My name is Robert, and I work at a clinic here in Spokane that primarily serves the chronic homeless. My segment here in this portion is going to be, I'm going to discuss kind of the racial inequalities in the healthcare system, access to services, and current kind of solutions that our clinic specifically within Providence Medical Group has been kind of working towards. So each year our clinic specifically has been in operation for about 5 years. And so each year, and it originally started within a shelter called the House of Charity here in Spokane, but then kind of transitioned out to its own brick and mortar location here in the downtown Spokane area. But with that, we provide walk-in access to kind of like a more urgent care setting. And each year we've kind of unturned a different stone as far as conceptualizing healthcare when it comes to homeless with our community specifically. So we want to keep that in mind. Each community may be different, but with Spokane and chronic homeless, our clinic is one of one as far as brick and mortar. So the things that we uncover each year is something that we try to learn from and try to come up with solutions to those barriers. But in regards specifically to racial disproportion, our clinic predominantly experience encounters with patients who identify as white or Caucasian. We do encounter some patients who are Black, Latino, Native American. However, as the word spreads that our clinic serves those despite of insurance coverage, because this is through Providence Foundation. So we bill insurance, but we don't necessarily collect if patients can't cover what's associated. So it's not necessarily a pure charity, but we do provide coverage if they're unable to. So despite insurance coverage, we have been encountering more refugees in our community. In this situation, we attempt to work with World Relief here in Spokane as they have access to an immigration attorney who can provide a more holistic community support for these patients. And so our clinic has encountered language, keyword here, language as a barrier to health literacy. Okay, so one qualitative observation we have noticed is that even though a patient may be able to speak English relatively well, comprehension of a care plan and explaining how body systems interact with each other and what their body is experiencing sometimes goes under the presumption that they fully understand an after visit summary or their care plan or what their medication changes are, etc. Now, with other healthcare settings, keep in mind, appointment adherence works out and access is achievable or is associated with what's called a medical home. So other healthcare settings can be associated with what's called a medical home, meaning capitation based. Even break it down even further, this means providers have limited time restrictions with each patient. And if you work with homelessness, you understand time is the most key important element for establishing a relationship and rapport. So when you have time restrictions related to being able to see a patient medically, that's a barrier right off the bat. So when providers have limited time, literacy of a care plan can often be presumed as fully comprehended if they speak English relatively well, right? If someone comes in speaking English relatively well, you would probably think that they could understand what's going on with their care plan. And this is not only in association with refugees, but can be observed with most of those experiencing chronic homelessness and who have low literacy and educational backgrounds. So that's kind of just a snapshot of the racial disproportion, at least that we see within our clinic location. Now, as far as access to services, this is kind of Pandora's box when serving this population. So to go over what we have in Spokane, our medical neighborhood consists of kind of two clinics or two medical homes, right? Going back to that capitation-based style. We have two kind of medical homes geographically located close to downtown Spokane, close to our clinic where we make referrals where patients can access primary care. Our clinic specifically is kind of a safety net care. We are bridge care that provides support so patients can attempt to get back into their primary care provider for that oversight. There's also an operation within Spokane called Street Medicine Team as well that goes and kind of does that same thing, but goes out to where the patient is rather than having a brick and mortar. So we have the primary care settings, the two medical homes, and then we have safety net care with our clinic and street medicine. But then you also cannot discount the utilization of the emergency department and urgent care systems here in Spokane, which is a huge, and I'll go over some numbers with you here shortly, but it's a kind of Patients who are experiencing homelessness have a cognitive repetition of continuing to go back to the urgent care, continuing to go back to the emergency department, because that's what they're familiar with. It's quick, it's accessible, it's walking, and you go there. And so with that comes along also emergency department discharges. So in Spokane, we have 2 primary hospitals who facilitate these discharges. And discharges can happen whether patients come in and then they're discharged, and they go about their day. Sometimes it's attempted if they're admitted into the hospital, that the discharge plan is then into 2 locations for respite support. Now this respite support currently, and we're currently kind of working towards solutions to this, but these respite locations are both men and women for hospitals have reserved beds within shelter systems for patients to go into once discharged from the hospital. Now there's certain criteria that patients have to meet before they're discharged into those beds, because again, they're just beds. That's kind of the support. There is some case management support within each of the locations, but again, they're just beds. So they don't provide any activities of daily living support, right? Standby support if the patient's a fall risk or if, anything like that. Social workers do attempt to provide what's called visiting nurses assistance within these shelter systems to provide wound care or anything like that. Now, the reason that these beds are required within Spokane, or not required, but support in Spokane, is that skilled nursing facilities, if a patient is experiencing homelessness and requires a skilled level amount of care, skilled nursing facilities then have the obligation to find placement for a patient before they're discharged. So skilled nursing facilities don't necessarily admit patients who are experiencing homelessness, because then they become responsible for finding that placement. So that's another barrier as far as not being able to get the care that's needed, and not getting the care if they're discharged into a shelter respite bed. Then you have also the aspect of hospice care, right? Giving patients the dignity while they're going through that end of life stage, having a placement set up for that. We do have hospice houses, but in order to be eligible for that, imminence has to be kind of on the doorstep, meaning you have to become within a certain amount of weeks before you pass. So there's not a lot of support there within the hospice realm. So we've talked about kind of the medical neighborhood, access to primary care, safety net care. We've talked about emergency department, urgent care utilization, and the cognitive repetition that's associated with that. And then we've talked about emergency department discharges within our community, skilled level care, and hospice support. Now, another aspect to consider as far as the overall holistic health of a patient is the psychiatric portion, the mental health concerns. Substance use organizations are a dime a dozen, so you're going to find a lot of outpatient and inpatient support that's available and utilized within our community. But that psychiatric support from a psychiatrist to be able to assist with medications for those who are wrestling with mental health concerns is desperately needed. So within our community of Spokane, the primarily insurance that most of our patients have is going to be Medicaid. And within our community, support for mental health service is monopolized, meaning it's kind of one large organization that provides that support, which makes it difficult because there are certain operation policies that patients have to navigate through in order to see a psychiatrist. So when I then go down into, we've talked about kind of the current access to services, I'm going to touch on the solutions and real solutions that our clinic specifically has been geared towards providing resolution or walk around to system barriers, etc. So with our clinic, we operate as an access first model. This is kind of just something that we've been not necessarily toying with, but like I said, each of these past 5 years, we've been unturning a stone, right? And so typically with this access first model, there are sequential orders in operation for status quo patients to meet before seeing a X provider, right? You have to complete A, B, and C before you get to see D provider. Well, with our population group, that's not necessarily feasible. I'll give you one primary example, even though there's multiple examples, that when patients are going to see a provider, I want you, first of all, everyone on this call, I'm horrible but for saying this, but making the assumption everyone has a home, right, to go back to within this call. But I want you to imagine for a second, okay, you have an appointment coming up. You just rented a U-Haul and you're gonna load up everything in your home just to go see your medical or psychiatric provider. You're gonna put everything in that U-Haul just to go to an appointment. The same thing is applicable for those experiencing homelessness. If they're camping out in the field or camping out at a park or on the other side of town, what are the chances that they're going to be willing to either trust their neighbor who's right next to them or pack up everything in their U-Haul just to go to an appointment? Chances are it's going to be pretty low. So how we've changed this approach, it begins on figuring out the scheduling piece and wraparound service to actually bridge the physiological needs and safety needs, right? Sometimes we forget that within Maslow hierarchy of needs, health falls into the category of safety needs. So our clinic bridges these two components within that hierarchy. I'll give you an example of what our clinic specifically does. So within our clinic, we don't make appointments, right? Appointment times are pointless usually. The adherence level is super low. So with scheduling, we have certain wraparound services and providers here on specific timeframes throughout the week. So let's say a individual is wanting to come in for psychiatric evaluation. Well, with our Access First model, that patient can come in to see a psychiatric provider on Tuesday afternoons between the hours of 1:30 to 5, first come, first serve. It's that time frame, that specific time slot. Or let's say they wanted to get, we have this support at our clinic with Rosemary Ware Disability Assistance Project to assist patients getting starting claims for SSI and SSDI. Well, if they want to access that support is available on Thursday mornings from 9 o'clock until 12:30. So there's specific time frames rather than come 3 weeks to now on the 3rd at 9 o'clock and be sure to pack up everything you own so you can make that appointment. We don't do that. We give certain time frames to kind of flex the schedule. And again, it starts with that access first, right? We want to give them access to the provider first, and then you fill in the blank with everything else. So right now, I'll kind of give you a snapshot of some numbers, and it's a small sample size, but it's something to take into consideration. Barry, if you could share kind of some of the document I have, I'll go over with you here. So in regards to the Access First model, right? So here we have the Spokane Teaching Health Clinic is who we partner with, and we're Providence Medical Group, a walk-in psychiatric clinic. So this walk-in psychiatric support is only based on 22 half days, right? Or 88 hours. We serve 51 patients. So within 4 hours, and this is a lot. I mean, it seems small, but within half days of doing psychiatric evaluations, it's pretty awesome. So with that, the primary diagnosis of these 51 patients here on this first one, you see that 36% have a dual diagnosis, right, for mental health. And then you get into 29% of PTSD and trauma. But when we go over the dual diagnosis, in Spokane, methamphetamine is kind of the primary player in regards to substance use disorder. And then you have alcohol and opioid use. Down below, you have a secondary diagnosis associated with that primary. And so with that, anxiety, and so on. So the appointment length, that's not necessarily relevant to you guys, or patient volume. But if we scroll down, here's another snapshot. Scroll down to the next, perfect. So this is in Spokane, we have what's called permanent supportive housing, meaning you are eligible for permanent supportive housing based on an assessment that determines you've been homeless for over a year. And then you have a disabling condition, which is different than an SSDI type of status. So with permanent support, and you qualify, you get like a certain score based off that assessment, and it's out of 60. And if you're in between 50 and 60, the better chances you are eligible for what's called housing first. In Spokane, we have a lot of housing first options that some organizations operate, and they're they're studio apartment complexes here in Spokane, and you can become eligible for this. So we took one of these permanent supportive housing because our clinic signs off on that disability verification based off of a chart review. We started tracking some things. So of the 43 patients we served in signing off on a disability verification, we noticed that 9% of them had no established primary care provider, and 12% had a primary care provider established. The rest utilize the emergency department. The emergency department is their primary healthcare provider, which obviously you're not going to get referrals to specialty care going to emergency department or urgent care, which is what is truly needed. And then we took another snapshot in regards to appointment adherence. So our clinic, we assist with scheduling appointments. We have RN care navigators here, and we assist with scheduling appointments, but also provide Uber Health transportation to those appointments from our clinic. So we give an access point from our clinic to kind of shuttle them out to whichever appointments they needed. 62% of them no-showed. And this one's different. This isn't based off the 43 patients we did for permanent supportive housing, but rather this portion here is in regards to the past 7 months of assisting 168 patients. 62% of them no-showed and 38% of them did make it. That's great. Now going back to the 43 patients we served and getting into housing first, 72% of those had a comorbidity, meaning they have something associated with mental health, substance use, a chronic health condition, and then 28% of them had a single diagnosis. And so if you scroll just a little bit further down, the comorbidity identifiers, there we go. So of those ones who had an association with a comorbidity, right, 32 of the 43, one of them were just a psychiatric identifier. One was had a substance use disorder underlying, and then, but a majority of them were 30 of them were co-occurring, meaning having both substance use and mental health. So this is kind of just a snapshot of what it looks like when patients are moving from the streets into housing. So, because there's a lot that comes with that. There's move-in guilt. There's, there's street families that they feel that they want to support, but also mental health and substance use are going into these housing first units. And some of these housing first models don't necessarily have the programming to support this. A lot of them do though, and that's great, but our clinic specifically tries to assist with providing that wraparound support as well, and assist these permanent supportive housing units the best we can in bridging that physiological needs and the health and safety needs. So bridging those two within the Maslow's hierarchy of needs. Again, there's a lot more to this, and like Julie said, I could talk about this for a long time, but I want to give Megan some time, and then we'll go to a Q&A portion. So I'll put my contact in the link if you want to reach out and email me about anything related to healthcare and homeless. Like I said, we try to be innovative in our approach and have a lot of support from Providence Foundation to address some of these barriers. but would love to connect with you if you're interested in learning more about the healthcare side for homeless. So Megan, I'll go ahead and hand it over to you.
Thank you, Robert. That was amazing to see, especially that last piece of data about the co-occurring. That really resonates with me, especially because we'd bail somebody out of jail, or we'd have somebody we're working with, and obviously high mental health, but can't address that mental health until the SUD is taken care of. And then we're on another wait list to get an assessment or get things. So thank you for that. So I wanted to share today, for over the last 2 years have worked primarily with individuals that are in our Spokane County detention services from 2019 into 2020 with the Bail Project. The Bail Project came here in December of 2018, and I was added to the Bail Project in about June of 2019. After about 6 months of bailing people out, they decided that they could use some extra help with connecting those people to the services in the community. And something interesting to note about the Bail Project, the reason that they came here was the racial disparities in our jail and the deaths that were happening in our jail. So I put together a small PowerPoint, and I just wanted to run through that really quick. I'm a data person, so I just thought if I could just show you some of the data. And if we can move to that for the second slide that actually talks about the jail population according to race. So this really brings it into, this really shows our racial disparities in our jail population. In Spokane County, they're incarcerating about 12% Black people. I think the bigger number is that only 70% are white. And in our community, our Black population is only about 2 to 3% on an average. So we're really over incarcerating those people of color in our jail. We can move to the next slide. And our jails, on the next slide, it talks about the impact of people that are from marginalized communities. Mostly the people that are impacted that are sitting in our jail here in Spokane or in most jails around the country are people of color, people with low income, people with disabilities, our LGBTQ population, people with histories of victimization and trauma. We often say that trauma is the gateway to incarceration and to being unhoused. And then of course, people with behavioral health needs, the people with mental health, substance use, and those co-occurring needs. We can move to the next slide. So I saw in the chat too that someone had said that a lot of times our participants in our programs will tell us it's just easier if I go to jail, because then if I go to jail, I can get housing. And it's kind of a reality. This is some data related to the Spokane County Jail, but it's true of most jails. Your average length of stay in a jail in the Spokane County Jail is about 18.5 days on an average. And that's a really short window if we're going to say, well, they can just go to jail and we'll make everything better. And that's an average. And then in our Spokane County Jail, if you're incarcerated in the Spokane County Jail, you are in the cage, bars closed 23 hours a day. You are out for 1 hour to make phone calls. There are no services added inside of the jail to help you or assist you. Accessing legal help doesn't even happen in that first 72 hours. So a lot happens inside of the jail to cause trauma, but not a lot happens in that jail, or I would say nothing happens in that jail that is actually rehabilitative. And that leads into jail not being a therapeutic setting. There's a limit to the effectiveness of even the best programs. I would go into the jail and meet people who were struggling with opiate use disorder and try to make a plan so when they come home, they won't immediately overdose. Let's get some things on board. And my access was very limited to those people and the ability to get them the medications that would block opiate use, even when it was free. So that's another thing to consider. And then even a short stay in jail disrupts what's going on right now in someone's life. It places a burden on our family and on our community. So if one of us, I would hope most of us on this call wouldn't wind up in jail, but let's say one of us does. A decision's made, maybe you have a DUI, because that's a really frequent thing that some of us could think of, or would have someone in our family who may have been incarcerated for that. So immediately, if a friend called you and said, I'm in jail, I have a DUI, my car has been impounded, I've got to get to work tomorrow, I don't know where my kids are, we would go and bail them out of jail. And we would get them to work the next day, or we would help call their employer and say, hey, they have court. A lot of people, especially our people who've been written a ticket for sit and lie, or are people who have been found somewhere with a substance that they use to maintain their life on the streets, are winding up in jail with no one to call and no way to get out. So, and a lot of our people are just one second away from being homeless again, or one life-altering event away from losing everything that they've worked really hard to get. So that 72 hours when someone is first in jail is so important that they have some services, but that's actually the time where there are no services present. And then we talked about the barriers to being able to be housed, but there are also collateral consequences to incarceration, and they last a lifetime. Just having that on your record that you've been arrested and what the charges were, even if you were found not guilty, that arrest still shows on your record. And in Washington State, they say that there are about 900 collateral consequences to being incarcerated. We can move to the next one. So arrests throw our lives into turmoil. Most often, the people who are impacted by jail, their circumstances are already really precarious, if that's a nice word to use, but their lives are already in total turmoil. And so incarceration just adds on top of that. In Spokane, when we were bailing people out of jail, our clients, about 86% of them reported a history of drug addiction or a history of substance use. 76% would tell us that they were unemployed, and 44% say that they are homeless or they have unstable housing, meaning if I don't get out today, I could lose what house I have, what couch I am sleeping on, what car I do have that I'm sleeping in. So this is what comes into play. Our pretrial system can either be a profound disruption or a positive intervention point for connecting people with supportive services. So pretrial is that period where you've been charged with something, but you've not yet been found guilty. Unfortunately, the presumption of guilt is there. We don't really carry a presumption of innocence in our country any longer. And then unfortunately, this presumption of guilt falls mostly on people who are marginalized. So our people of color, LGBTQ people, and people who are really, really experiencing poverty. So what we can do in that pretrial period is offer supportive services such as housing assistance, job training, and substance abuse treatment. And I think one of the most powerful things that we can offer is that peer support or a peer intervention. Someone who's been there, done it, someone who has lived experience who can step in and say, hey, this is a path to get you to where you need to go. And we can move to the next slide. So designed housing, and I took this model from a project that was a work group that was established in Los Angeles, and it was called the ATI work group, Alternatives to Incarceration. And what they basically said was, we have to expand or refine our affordable, successful housing models designed and tailored for justice-involved individuals, those with mental health and those with substance use disorders. So we have to have a short-term treatment inclusive of acute inpatient. So that means we have to have places where people can go immediately and access inpatient. And then we have to have the forensic inpatient and the IMD or subacute bed. So people that can go with their medical issues or that have subacute problems can go and have a bed. Secondly, or B, we need to have interim housing that's inclusive of clubhouse living, supportive employment. That's where those peers come in, places where people are able to go and live. And then that recovery bridge housing and sober living. So we have to first have somewhere that they can go to be supportive, to get sober, or to get to that point where they're able to then live in a recovery house, where they won't move in somewhere and, oh, you relapsed, you suffered, you had some trauma, and now you have to pack everything your own. And as Robert would say, pack up your U-Haul and leave in 15 minutes. And then secondly, or thirdly, we have to have permanent subsidized housing that's inclusive of independent living and board and care facilities. So we have to have all of those things, all three of those things in our permanent subsidized housing. So we have to give people the start and then follow them all the way through into housing. That's all I've got on my PowerPoint. I wanted to add some information that that has been shared with our community, and I think it's some really, really important information. And I wanted to talk about some of the people that I recently worked with or have worked with at through the Bail Project and through my outreach when I worked navigating people into medically assisted treatment for opiate use disorder. So my good friend and the founder and director of Compassionate Addiction Treatment here in Spokane, our low barrier treatment agency, shared this information from the National Law Center on Homelessness and Poverty. And it's the most recent annual survey. And it lists the reasons for people to be unhoused. Families listed the #1 reason for being unhoused, lack of affordable housing. The #2 reason, unemployment. The #3 reason, poverty. And the #4 reason, low wages. Now, singles listed these items as their reasons for being unhoused or for experiencing homelessness: lack of affordable housing, unemployment, poverty. Fourth was mental illness, and fifth was substance use and a lack of human services to deal with this substance use disorder. So when we think about the reasons that people are unhoused, because there's funding in our community, the funds just need to be spent to provide the access for people. We need this low barrier access. We would encounter people that were in jail, and we would immediately start to work to create a plan. What's our plan for bringing these people home? We can't post your bail. And in a lot of instances, there wasn't bail that needed to be posted. What we needed to do was coordinate their care plan with the community so that we had a plan. So a judge would say, okay, I agree, because bail is supposed to be something that is set to ensure people will return to court. It's not a punishment. It's not something that says you can afford, and it's supposed to be affordable. So if I'm a person who doesn't have any money, then giving me $100 bail is like giving me $1 million bail. So we would go to work on connecting people with what's needed in the community. And what comes to mind is a gentleman who was a veteran, a Black male, a veteran who we bailed out, and he came into the office and he said, I'm really mad at you guys, because when you came to meet me in jail, you told me you were going to connect me with your services in the community. And we had created this plan where he would access veteran services and he would be able to be housed. And he immediately said to us, I would rather be in that jail than out here trying to access services in our community. There's no way that I'm going to be able to do this. And we would put him in an Uber and take him to different things. And his barriers were immense. And he wasn't able to access any of the services that were offered for him because of his barriers. So fast forward, we see him 6 months later, and he says, I finally got in somewhere. I finally got someone to take me to that appointment. I finally got help with that issue. And nothing happens overnight. So everything is going to take an additional amount of time. But in that time that he struggled to get in, he missed court dates and he would go back to jail. And then he'd have another charge for missing the court date. And then he'd go back to jail again and he'd miss a court date. So there's a continuous cycle when we throw people in jail that just adds more trauma on top of the trauma that they've already experienced. I think one of the other pieces of data that's very important for us to remember, especially as we go into this heat wave And the city has provided what they call cooling centers. And there's no access to the cooling centers as far as transportation. And the city will say that they don't have the money to provide the transportation to the cooling centers. Well, they're not offering low barrier transportation. They're not opening up the bus systems and saying, here, ride the bus, go how you want to. The funny thing, and it's not really funny, but it's hypocritical of our city to say they don't have the ability to transport people and they don't want to pay $56 a night for a shelter bed. They will immediately dispatch a police officer and put that person in a police car and take them to the Spokane County Jail and keep them in jail at $135 a night and use those funds. Our jail right now is sitting at around 740 people incarcerated. During COVID, and the incarcerated number in our jail went down around 400. So our jail has the ability to decarcerate. They have the ability to, our city has the ability to open shelters. They choose not to open the shelters and to provide low barrier shelters because they would rather incarcerate people in the jail and create their $135 a night in profit. And that's something we really, really have to remember. And then we've had instances where we participate in what's called participatory defense, which is something that our group, All of Us or None, does. We meet individuals, we meet with their family, we go to court, we set up a plan. As a substance use disorder professional, we have an assessment done on them, and we create a plan for them to not be incarcerated and to move forward to access the low barrier services, starting off with inpatient treatment. So the judge will sign an order for them to go to inpatient treatment. They go to inpatient treatment, they're returned back to the jail. They go back to another court date and they go in front of the judge and they tell the judge, I finished my inpatient treatment and now I need to be released so I can be in the community so that I can do my outpatient treatment and begin the process of being housed. And the judge says, I can't release you because you don't have housing. But how is this person supposed to access housing unless he's released and added to a low barrier system with peers and with all of the resources? So I would agree with what Julie said in the very beginning of our program. She said that the resources are there. It's a connectivity issue. A lot of times we couldn't connect the people to the resources that they needed, or the resource that they needed had all the barriers. I could meet someone in jail and he could tell me, I can't go back to XYZ shelter, and I'm being nice calling them XYZ, because I have to pay $3 and do a UA, and I won't be able to pass that UA because I've used substances in the last 30 days. So again, a person sits in jail while the system profits off of their incarceration when the person should be out accessing a low barrier shelter and gaining employment, which is the number one thing that people need to be housed. They need that funding. They need affordable housing. So I think as we progress in our systems and as providers, we have to look at what barriers are even inside the systems that we're working in, what biases are included in our minds that we need to remove, and what is our carceral system, how can they look at themselves and think, what barriers are we presenting and how are we disproportionately impacting people of color in our court systems, in our shelters, in all areas? How are we disproportionately impacting those people of color? So thank you.
Okay, thank you, panel. I am going to go as quickly as possible because I want to leave time for questions. And as I'm listening to this, I'm thinking of something. One thing I've done here in Spokane for about the last 10, 12 years is a program called Urban Plunge, where I take groups of people, church groups, school groups, civic groups, and spend either from a few hours to like a day, taking them around downtown, basically educating them on homelessness, like what you're getting right now. The key thing I would provide was access to people who actually have lived experience. We would talk to people in shelters. So we would talk to people who had been homeless for years. Those stories were very impactful. And I just put in the chat, I'm willing to organize something on Zoom like that for anybody in this room right now. I've done that a lot. I haven't done it on Zoom. I've always done it in person. With COVID, I've stopped. But I realized from listening to this may be something that would be a benefit on a Zoom basis. Anyway, so that's that. My topic, and if you want the full thing, I can email it to you. I'm just going to go for bullet points. Basically, homelessness, way overrepresentation by BIPOC individuals, you know that. Employment barriers, they're huge. Causes of homelessness, people have covered it. The basic one is lack of housing. If there was sufficient housing, people could be housed. But because there's insufficient housing, there's a scramble for it. And if you're poor, you ain't gonna get it. If you've suffered a lot of trauma, you ain't gonna get it. If you have lost the support of family and community and don't have the resources that can help you get that housing, you're not gonna get it. And someone in the chat put, there's a whole spectrum. There's the street homeless that holds a sign that's been on the street for years. Those are the people that you have the picture of. But the state of Washington counts about 60,000. Of those, probably 5 to 10,000 are like those chronic street homeless. A very large proportion are housing insecure. They're doubled up. They're couch searching, couch surfing. So there's a real broad spectrum of what would come under the definition of homelessness. A very large percentage of homeless in that broader definition are kids. There's families with kids. Legally, I can send you, I've got a little information, but if you have any legal resources to ban the box, so if someone's applying for jobs, the state of Washington has a law that says you can't initially ask, do you have a criminal record? Clean slate laws. There are ways that after a period of time, you can get your record expunged. In Washington, that's really hard. In most states, that's really hard. But someone asked about advocacy. A couple of years ago, the legislature passed a very easy, time sensitive, like, after 7 years, it's automatically expunged. The governor vetoed that. Don't know why, but that is one legislative thing you could do. I'm going to put in the chat a list of local homeless coalitions, like Tacoma, Seattle, Kitsap, Vancouver. So if you want to get involved on your local level, I'll put that in the chat in just a moment. But you can also email me and I'll send you the whole thing. Okay, that's about it. Question, Julie, I'll send it back to you. Questions in chat or questions and answers, other folks?
Thank you, Barry. One of the questions I saw posted in the chat is what's done about the legislative process to getting these issues addressed. I'm going to speak from just the local level. That's actually where we advocate for the homeless that we serve, and the population I serve is the chronically homeless. There are actually laws and RCWs put in place in our city that address these. The problem is who is held accountable to those laws? Nobody is checking to see if those laws are followed. As it is right now in the county in which we live in, there is roughly 60 beds available in our shelter system and 5,000 unsheltered folks by our city's data. A RCW was put into place stating that low barrier beds we cannot enforce without those low barrier bed numbers being adequate to our population, yet we just hired 2 more pod enforcement officers to now go out 7 days a week moving homeless folks. And we have added 0 beds to our shelter system. There's also an RCW that states that low barrier beds in our city cannot be taken away from people experiencing homelessness unless they are able to show that there is not a need. We recently closed a homeless shelter within the last month and a half that served 102 low barrier beds with no replacement beds for those folks. So there are legislation that protects these folks. The problem is nobody is held accountable to adhere to them, at least in our county. Barry, you want to ask whatever, there's questions for Megan as well.
Let's see. Oh, yeah. Megan in chat says, Megan seems to imply that $135 incarceration cost per night is a profit to the city. I don't understand how this works.
It actually is. They charge $135 a night for people to sleep in a bed at the jail. And it actually funds a whole industry where they employ people. And so yeah, it's $135 a night when it would cost the city $56 to have a shelter bed. And then there are providers that would come into that shelter and provide their services in that shelter. So it is. And the rate is sometimes higher when you look at a prison bed, how much it costs to run a prison, but it is actually an industry that does create profit, or there is a profit in it.
Okay, we don't have any questions. So panelists, give some more information. Oh, let's see. I saw one just came in. Let's see if it says what it says here. Do you have any suggestions about lowering barriers to access legal services?
Barry, you're the lawyer.
Well, there are a few free legal services in Spokane and probably throughout the state, but they're minimal. And there, obviously there's the criminal. If you're there's criminal defense, there's public defenders, but civil, there's really very little. And the same type of barriers that like Robert was describing about getting healthcare services applies to, especially chronically street homeless folks. Like, okay, when's my appointment and where do I go? And we'll bring your paperwork with you. Oh yeah, none of that is going to work. There's street outreach there's doctors that go out on the street and help. There's Julie and her group that go out in the street and help. I doubt if there's many legal people. I hope there would be, but I don't know of any that actually go out on the street. My guess is every single homeless person on the street would have a wealth of legal things that they could use help with. So I think it's a lack of availability of the service, and it's, volunteer lawyers. We would need an army. Somebody else?
I think that, oh, sorry, did you want to go, Julie? I think that we need to add legal service places where, much like the clinic that Robert Lipman is at, where people can walk in and are able to receive legal services. I think one of the other things that we didn't discuss today on this call, and people that I work with, are the parents experiencing homelessness, primarily parents of color, and a lot of times, and most of the time, Indigenous women who lose their children due to being unhoused, and then don't have access to legal help to get those children back, or even to access housing. So my answer for lowering those barriers is to put in legal clinics in the places where people have to access the court system. So there would be a walk-in legal clinic at our courthouse, and there would be a walk-in legal clinic next to the CPS building, or in every community. And we need to make sure that those places are accessible so that we can put families back together.
One of the things in our community that helps with criminalization of homelessness is community court. We actually have a community court that opens up access to services for people experiencing homelessness who have been charged with a law that it pertains simply to being homeless. We didn't speak a lot about community court, but if you would like to know about community court and how it works, I would be happy to answer any questions in your chat or via email.
Keep asking the questions, folks, in the chat if you have them. Or panelists, if you have something you want to add.
I want to answer one part of the question. Why do homeless people Why don't they just get a job? Well, I'm going to start with one of the very basic things that people don't usually know about homelessness is most people experiencing homelessness do not have access to their core documents, which means they have no ID, no social security card, no insurance card, because that stuff is taken in police sweeps and stolen on a regular basis. Getting a job requires those things, and those things take time, especially now during COVID. We have seen an increase in those needs and a decrease in the accessibility to get them. So that's the first barrier. Secondly, they don't have a place to shower, a place to sleep. How do they know how to get there? And personally, from a person out on the street, how do you show up to a place of employment smelling like you smelled yesterday? Because in my county, I'm the only provider of low barrier shelters to people experiencing homelessness. If they don't get to my shower trailer where it's located, they don't get a shower for that week. And they have to carry all of their things. When my partner is in an employer in the downtown area, and we do employ people experiencing homelessness. One of their biggest barriers is, where do I put my things? Where do I bring my cart? Where do I take my bike? Those are the problems, because as Robert stated, everywhere you go, when you experience homelessness, every item that you own goes with you. Otherwise, when you come back, there is no item left.
One question in the chat is, there are presently several mutual aid groups that are providing support to the unhoused community in response to the violent sweeps at encampments here in Spokane. It's called Stop the Sweeps. What are the ways your respective groups work with mutual aid projects? I assume mutual aid is what I just responded to, the Stop the Sweeps thing that's happening here in Spokane. And how are people able to mobilize? The way they did it is we had a monthly Zoom meeting for our homeless coalition, and that group of people just said, hey, we want to do something. They got together, organized on their own, and started a petition and advocated our city council. And they wanted to have Zoom homeless lived experience people testify at that, but to do so, you had to put an address. There was a barrier. Homeless people couldn't testify before the city council via Zoom because they had no address. Just one of the barriers many people face. One question asked, is there a one-stop shop for help unhoused people? I'd say Julie Garcia, what is it?
In theory, there is. In theory, we have something called the Envision Center where service providers are all there at the same time. The problems are still the same as they are everywhere else. And COVID has highlighted that. We need to serve people where they are, because where we think they should be isn't where they're going to access service. It's
Before
real
we
plain
end,
and simple.
Before we end our panel, I just want to remind everybody that unhoused people are able to vote, and that we should be doing everything we can to register everyone to vote and explaining to them their ability to change and influence the system.
Barbara, I think you need to say goodbye to us.
Okay. All right. Well, thank you everybody for coming. We will now be having our lunch break, and I want to give a special thanks to our panelists. I thought they did an amazing job. Thank you so much.
Yay, panelists. Can we stay on with anybody who wants to stay on with this, Barbara and Laura?
I think I've been instructed to close the session.
Okay.
So you certainly can re-engage with, exactly. You can re-engage through email in other ways, but thank you so much for coming, everyone.
Okay.
Thanks, everybody.
Thank you. Thank you.
Have a great lunch.